Welcome to the Neurostimulation Podcast. I'm Michael Passmore, Clinical Associate Professor in the Department of Psychiatry at the University of British Columbia in beautiful Vancouver, Canada. The Neurostimulation Podcast is all about bringing cutting-edge neuroscience education to you free of charge. Every week, I'm going to explore the fascinating world of neuroscience in general and neurostimulation in particular. We'll look at how it works, what are the latest research breakthroughs, and most importantly, how is that research being translated into real-world treatments that can improve health and well-being? So whether you're a healthcare professional, a student, or just someone who's interested in how our brains work and what we can do to help them work better, this podcast is for you. My mission is to make the science accessible, inspiring, and relevant to your life. As part of my commitment to an evidence-based analysis, in each episode that we discuss a specific study, I'm going to offer an advanced critical appraisal of that study. If you're not interested in this deeper dive into the methodology, feel free to skip ahead on the timeline to focus in on other areas of the discussion that you're more interested in. This podcast is separate from my clinical and academic roles and is part of my personal effort to bring neuroscience education to the general public. Accordingly, I would like to emphasize that the information shared in this podcast is for educational purposes only and is not intended as medical advice or a substitute for professional medical guidance. Always consult with your own healthcare provider to discuss your particular healthcare needs and treatment options. By listening to or watching this podcast, you acknowledge and agree that any decisions related to your own health are your responsibility, and I would recommend that those decisions be made in consultation with a qualified medical professional. This episode is presented by ZipStim Neurostimulation. Full disclosure, ZipStim is the neurostimulation clinic that I own and operate. You can find out more about our clinical neurostimulation programs at zipstim.com. That's ZIPSTIM.com. Now let's get started. Today we're diving into the realm of Transcranial Direct Current Stimulation, or tDCS, for the treatment of migraine headaches. We'll be discussing a high-impact study titled Transcranial Direct Current Stimulation for Migraine, a systematic review and meta-analysis of randomized controlled trials by Hong and colleagues. This study is pivotal because it aggregates data from multiple randomized controlled trials to give us a clearer picture of tDCS's efficacy and safety in managing one of the most common neurological disorders, migraines. My aim today is to unpack this study's findings, provide a comprehensive review, and offer an advanced critical appraisal in line with evidence-based medicine principles. We're going to explore how these results might influence clinical practice and what we might look forward to in future research. Migraine headaches affect millions worldwide, often leading to significant disability. Current treatments have their limitations, prompting research into non-pharmacological methods like tDCS, which involves applying a small electrical current to the scalp in order to modulate brain activity. tDCS is a non-invasive neurostimulation technique that's safe and can be applied in various settings, making it an attractive option for treatment of migraines and for prevention. But just how effective is it, and does it stand up to scrutiny in clinical trials? That's what we're going to explore today. If you've ever been curious about alternative treatment options for migraine headaches, or you're someone who deals with migraines and might be considering tDCS, this episode is for you. Stay tuned as we delve into the science behind this potentially transformative treatment. We'll also critique the study's methodology, results, and implications, so you'll leave with a well-rounded understanding of where tDCS stands in migraine treatment today. We're going to start with an overview of the study, and then move into a detailed discussion of its findings, followed by a critical appraisal where we'll dissect the study's validity, reliability, and clinical applicability. Finally, we'll consider what this means for the future of migraine treatment. As always, feel free to share your thoughts or questions about tDCS or migraines on our social media platforms in the comment section below or through our website at zipstim.com. Let's begin this journey into understanding how we might use electricity to alleviate one of the most debilitating conditions known to medicine. First, let's talk about migraines. Affecting about 12% of the global population, migraines are not just bad headaches. They're a complex neurological condition that can be debilitating. They involve throbbing pain, often on one side of the head, often accompanied by things like nausea, vomiting, and sensitivity to light and sound. The treatment of migraines has traditionally revolved around pharmaceuticals, from over-the-counter pain relievers for acute attacks to preventative medications like beta blockers or antidepressants. However, these treatments don't work for everyone, and they can come with significant side effects, pushing the search for alternative therapies. tDCS, or Transcranial Direct Current Stimulation, is a form of non-invasive brain stimulation. It involves placing electrodes on the scalp and passing a low-intensity electrical current to modulate the activity of neurons in targeted brain areas. Think of it as gently nudging the brain's activity in one direction or another. The mechanism isn't fully understood, but is thought to involve changing the resting membrane potential of neurons, thus altering their excitability. For migraine headaches, tDCS targets areas like the motor cortex or visual cortex associated with pain processing and cortical spreading. For migraines, tDCS targets areas like the motor cortex or visual cortex, areas associated with pain processing and cortical spreading depression, which is a hallmark of migraine attacks.
Alas, poor Yorick. I knew him, Horatio. A fellow of infinite jest, of most excellent fancy.
Alas, poor Yorick, here we have not just any brain, but the key player in our recent study on transcranial direct current stimulation for migraines. So let's start with the motor cortex, or as I like to call it with Yorick, the movement maestro. It's right here on the frontal part of the cerebral cortex here, this red strip here, M1. It's often targeted in migraine studies because it's linked to pain perception and modulation. If Yorick here could feel, this is where we'd zap him to ease those pesky headaches. Next up, we have the visual cortex, which is at the back here of Yorick's brain. This region, which is nestled in the so-called occipital lobes, is also a primary target for tDCS in migraine treatment, particularly for those who experience visual auras before their headaches. Think of it as turning down the visual noise before it turns into a migraine symphony. Now, let's not overlook the dorsolateral prefrontal cortex up here in the frontal lobes at the kind of the front of where this pink area is here. It's a bit of a brainy area dealing with executive functioning like decision-making and planning. In the context of migraine, stimulating this region might help with the cognitive aspects, perhaps reducing the mental fog that often accompanies an attack. And then there's the somatosensory cortex, which is right here over the parietal lobes in this kind of purple or bluish-gray area here. This is where sensations from the body are processed. So stimulating this area with tDCS could potentially alter how pain signals are perceived, giving a bit more relief. Of course, all of these regions are interconnected through the white matter, which is kind of like the brain's internet. We know that it is crucial for the electrical impulses from tDCS to reach their targets effectively. Here you can see on this mid-sagittal view the corpus callosum, which is kind of the main tract of white matter that connects both hemispheres. And lastly, while we don't directly zap the brain stem, which is this area down here, this area manages basic functions like sleep and wakefulness, which can be disturbed in migraine sufferers. If Yorick here had migraines, we would want to ensure that any intervention respected this vital control center. There's a view of the brainstem from below here. So there you have it, a tour of your in the context of this tDCS and migraine study that we've been talking about. Remember, this is not just about understanding brain anatomy. It's about understanding how we might harness this complex organ's power to alleviate one of life's most debilitating conditions. Okay, now back to the shelf with you, Yorick, where you can ponder the mysteries of the brain in peace. The appeal of tDCS lies in its potential to manage migraines with fewer side effects than medications, offering a non-pharmacological option. It's been explored for conditions like depression and stroke recovery, so the leap to migraines is both innovative and grounded in existing research. We've seen a surge in research exploring its applications from cognitive enhancement to pain relief, including migraine management. Before diving into the specifics of the Hong and colleagues study, it's worth noting that earlier research has shown mixed results. Some studies suggested benefits in reducing migraine frequency and severity, while others found no significant impact, setting the stage for comprehensive reviews like the one that we're discussing today. The landscape of tDCS research for migraines is growing, with various studies targeting different brain regions, stimulation protocols, and patient groups. This diversity in research approach is crucial, but also makes it challenging to draw definitive conclusions without systematic reviews and meta-analyses. With that background, we can now appreciate why the study that we're about to discuss is so significant. It synthesizes what we know so far about tDCS in migraine management, potentially guiding future clinical practice. So let's move into the specifics of what Hong and colleagues discovered. The study that we're discussing today is titled Transcranial Direct Current Stimulation for Migraine, a systematic review and meta-analysis of randomized controlled trials by Hong and colleagues, published in the journal CNS Neuroscience and Therapeutics. This meta-analysis was conducted by a team led by Hong, with contributions from various researchers in the field of neurology and neuroscience, aiming to consolidate evidence on tDCS's role in migraine treatment. The authors searched multiple databases, including PubMed, Embase, and the Cochrane Library, up to December 2021, focusing on randomized controlled trials involving tDCS for migraines. They used specific terms to ensure that they captured all of the relevant studies. Only randomized controlled trials with adult participants, clear definitions of migraine, and employing tDCS as an intervention were studied. Studies without adequate control groups or insufficient outcome data were excluded. They assessed the risk of bias in individual studies using the Cochrane Risk of Bias tool, which helped in evaluating the reliability of the trial results. One of the most compelling findings in the study was that tDCS, particularly when applied to the primary motor cortex, or M1, or the visual cortex, or VC, significantly reduced the number of migraine days per month. This effect was evident in the short term, with some studies showing benefits extending to 3 months post-treatment. There was also a notable decrease in pain intensity among patients who received active tDCS compared to sham stimulation, indicating not just fewer migraines, but also less severe ones when they did occur. Safety was another critical area of focus. The meta-analysis found no significant difference in adverse events between active and sham tDCS groups, suggesting that tDCS is well tolerated when properly administered. Common side effects like skin irritation were minor and transient. The study reviewed different brain stimulation sites: M1, S1 or somatosensory cortex, DLPFC, dorsolateral prefrontal cortex, and VC, with M1 and VC showing the most consistent benefits. These results indicate that targeting these areas might be key to achieving therapeutic effects in migraine. The protocols varied, but generally sessions lasted between 20 and 30 minutes, with treatments occurring daily or several times a week. The study suggests that longer courses of treatment might be more beneficial for sustained effects. The effect sizes were calculated using weighted mean differences for continuous outcomes like migraine days per month. This allowed for a more standardized comparison across different studies. There was significant heterogeneity among the studies, which the authors addressed by using both fixed and random effects model in their meta-analysis to provide a comprehensive view of the data. In conclusion, this meta-analysis supports the use of tDCS as a promising adjunctive or alternative treatment for migraines, showing benefits in both frequency and severity of attacks. However, the authors also acknowledge the need for larger, more uniform studies to confirm these findings and to explore long-term effects. These results could influence clinical guidelines, encouraging more research and possibly the integration of tDCS into migraine management. These results are encouraging in terms of influencing clinical guidelines, encouraging more research, as well as the integration of tDCS into migraine management protocols, especially for those who are resistant to traditional therapies or looking for alternative treatment options. Let's dive deeper into how tDCS might work for migraines. It's believed that by modulating cortical excitability, tDCS can alter pain pathways or reduce the likelihood of cortical spreading depression, the wave of brain activity that's thought to be crucial in the initiation of migraines. This could explain why targeting specific areas like M1 or VC was effective. Another angle is the induction of neuroplasticity, where tDCS might promote changes in brain structure or function, offering long-term benefits in migraine prophylaxis or prevention. The study highlighted the effectiveness of targeting the primary motor cortex, or M1, and the visual cortex, or VC. M1 might influence pain perception and the trigeminal system, which is heavily involved in migraine pathophysiology. Similarly, VC stimulation could prevent the visual aura that precedes migraines in some individuals, or modulate visual processing to reduce migraine triggers. While M1 and VC showed promise, the dorsolateral prefrontal cortex, or DLPFC, and somatosensory cortex, or S1, were also studied, but with less conclusive results. This might suggest a tailored approach based on individual migraine characteristics. One major limitation is the variability across studies in terms of stimulation parameters, patient demographics, and migraine subtypes. This heterogeneity can muddy the waters when trying to draw definitive conclusions from meta-analyses. Many of the included studies had small sample sizes, which can lead to issues with statistical power and the detection of small but significant effects or rare adverse events. Most studies only looked at short-term outcomes. We need more research to understand the long-term efficacy and safety of tDCS for migraines. The success of blinding in these trials is crucial, as the placebo effect can be strong in pain relief studies. The study didn't delve deeply into how well participants and researchers were blinded to the treatment. For clinicians, this study suggests that tDCS could be considered as part of a multimodal approach to migraine management, particularly for those who are not responding well to traditional therapies. However, it should be used cautiously due to the need for more robust evidence. Patients with specific migraine characteristics, like those with aura or those predominantly experiencing pain in certain areas, might benefit more from tDCS. Personalized medicine could play a role here. From a patient's viewpoint, tDCS might be appealing due to its non-invasive nature and potentially fewer side effects than medications. However, accessibility to this technology, training for its use, and cost could be potential barriers. We urgently need studies that follow patients over longer periods to assess if tDCS can potentially provide sustained relief or if there's a risk of tolerance or rebound effects. More head-to-head comparisons with existing treatments would help position tDCS in the therapeutic landscape. Also, exploring different migraine types or phases, like during an attack versus preventative use, could yield insightful data. Advances in tDCS technology, like more sophisticated targeting or combining it with other neuromodulation techniques, could potentially enhance its efficacy. Based on the findings from Hong and colleagues' study, tDCS could be considered as an adjunct or alternative therapy in the clinical management of migraines, especially for patients who may have not responded well to conventional treatments or who are looking for an alternative option. Clinicians might start integrating tDCS into treatment plans, perhaps starting with those patients exhibiting resistance to pharmacological interventions or those who are looking for different options. Clinicians might start integrating tDCS into treatment plans, perhaps starting with those patients exhibiting resistance to pharmacological interventions. The study's results highlight the need for standardized tDCS protocols. Clinicians would need to determine optimal stimulation parameters, such as duration, frequency, and targeted brain regions, possibly tailoring these based on individual patient response and migraine characteristics. The research suggests that patients with migraines who have a significant cortical component to their pain, or those experiencing aura, might see the most benefit from tDCS. Those with chronic migraines or frequent attacks could also be prime candidates, given the preventative aspect of tDCS. However, caution is advised for certain groups like pregnant women, individuals with pacemakers, or those with a history of seizures where tDCS might not be entirely safe or suitable. The adoption of tDCS requires clinicians to gain expertise in its use. This includes understanding the device, monitoring for adverse effects, and interpreting patient responses. Clinician training programs or collaboration with neurologists specializing in neuromodulation. Clinician training programs or courses on training programs or collaboration with physicians specializing in neuromodulation could be necessary. Clinics would need to invest in tDCS equipment, which might not be universally accessible or affordable, potentially posing a barrier to widespread implementation. While this study showed a good safety profile, real-world application requires ongoing monitoring for any adverse effects. Establishing protocols for patient follow-up, adjusting stimulation based on feedback, and documenting any side effects will be crucial. Given that most studies only looked at short-term outcomes, clinicians should monitor patients for long-term effects or changes in migraine patterns over time. Educating patients about what tDCS entails, including an explanation of the potential benefits, the risks, as well as offering an understanding that it might not work for everyone and that it's likely going to be part of a broader treatment strategy for migraines, will all be very important. Setting realistic expectations will be important. tDCS may not eliminate migraines, but likely will reduce their frequency and/or severity, which would still represent a significant improvement in patient quality of life. There is a need to bridge the gap between research findings and clinical practice. This involves not just reading studies, but also contributing to them by participating in clinical trials or collecting real-world data on tDCS use. Clinicians should contribute to ongoing research by providing feedback on patient outcomes, helping to refine tDCS protocols and identify predictors of response. Professional bodies might need to develop specific guidelines or recommendations for tDCS in migraine treatment, reflecting the latest evidence and expert consensus on best practices. Advocacy for insurance coverage or policy changes to include tDCS could be necessary to increase accessibility, especially if its effectiveness in reducing healthcare costs for chronic migraine management is demonstrated. Given the limitations due to small sample sizes in many of the studies reviewed, there's a clear need for larger, multi-center trials. This would provide more robust data on tDCS's efficacy and safety across a broader demographic, potentially leading to more generalizable results. We need studies that follow patients for longer periods to evaluate not just the immediate effects, but also the sustainability of tDCS in migraine management. This could reveal if there's any risk of diminishing returns or if benefits persist over months or years. Future research should also delve into different migraine subtypes, like chronic versus episodic migraine, migraine with aura versus migraine without aura. Understanding if tDCS benefits vary by migraine type could guide more personalized treatment plans. The Hong and colleagues' study didn't find any sex differences in the tDCS response, but given other research suggesting that sex impacts migraine pathology and treatment response, this area deserves more attention. There's potential in exploring tDCS not just for prevention, but also during an acute migraine attack. Studies could compare its efficacy in aborting an attack versus its preventative use. Technological improvements could include better electrode designs for more precise targeting, or integration with real-time EEG or fMRI to tailor stimulation based on current brain activity. Exploring combinations of tDCS with other treatments like medications or other forms of clinical neurostimulation like TMS could potentially uncover synergistic effects, potentially enhancing patient outcomes. More research into how exactly tDCS alters brain function in migraine patients could refine our approach. This might involve looking at changes in neurotransmitter levels, cortical excitability, or even genetic markers that predict response to tDCS. Utilizing advanced neuroimaging pre- and post-tDCS could help visualize changes in brain structure or function, providing insights into why some patients respond better than others. Future studies should include quality of life, productivity, and psychological well-being as outcomes, not just the number of migraine days or pain intensity. This holistic approach would better reflect the real impact of tDCS on patients. Capturing patient narratives through qualitative studies could also enrich our understanding, highlighting aspects like treatment acceptability, comfort, and long-term adherence. To move tDCS from research into more routine clinical practice, standardization of protocols, devices, and outcome measures is going to be crucial. This will help in regulatory approvals and guideline development. Ensuring ethical practices in tDCS research, especially regarding informed consent, blinding, and patient safety, will also be vital as we push into more invasive or prolonged treatments. So we've explored how the systematic and meta-analysis by Hong and colleagues, which provided compelling evidence on the efficacy of tDCS for reducing migraine frequency and pain intensity with a good safety profile compared to sham treatments. Our critical analysis highlighted the study's strengths in pooling high-quality randomized controlled trial data, but also pointed out limitations like study heterogeneity, small sample sizes, and a focus on short-term outcomes. Clinically, this study pushes forward the conversation on integrating non-pharmacological treatments like tDCS into migraine management protocols, particularly for those not fully helped by conventional methods. We've also discussed numerous avenues for future research, from larger trials to focused studies on different migraine types, and the need for long-term outcome data. The field of clinical neurostimulation for migraines is dynamic, with tDCS showing a lot of promise. However, we're at an exciting frontier where each new study can significantly alter our understanding and application of these techniques. For those living with migraines, Engaging with your healthcare provider about new treatments like tDCS and even potentially participating in research can be empowering and can contribute to the collective knowledge. Transcranial Direct Current Stimulation. Here's an advanced critical appraisal of the study Transcranial Direct Current Stimulation for Migraine, a systematic review and meta-analysis of randomized controlled trials by Hong and colleagues using the PRISMA approach, which stands for Preferred Reporting Items for Systematic Reviews and Meta-Analyses. Here's an advanced critical appraisal of the study Transcranial Direct Current Stimulation for Migraine, a systematic review and meta-analysis of randomized controlled trials by Hong and colleagues using the PRISMA checklist. PRISMA stands for Preferred Reporting Items for Systematic Reviews and Meta-Analyses. We're going to use the PRISMA checklist to critically appraise this meta-analysis, ensuring that we cover all aspects of systematic review quality. We're going to use the PRISMA checklist to critically appraise this meta-analysis, ensuring that we cover all aspects of systematic review quality. First, the title and abstract evaluation. The title clearly indicates that it's a meta-analysis on tDCS for migraines, which is good for transparency. The abstract succinctly outlines the background, methods, results, and conclusions, although it could have expanded more on the implications for clinical practice. Next is the introduction and background. The introduction sets the stage well by describing migraines' prevalence and the rationale for exploring tDCS. However, it could have included a clearer statement of objectives and perhaps acknowledged other systematic reviews to position this study within existing literature. Next is methods and eligibility criteria clarity. The criteria for study inclusion are well defined using the PICOS framework, which is commendable. However, exclusion of conference abstracts might have omitted preliminary but significant findings. Next is information sources and search comprehensiveness. The search was conducted across major databases, which is thorough, yet the cutoff date of December 2021 means that there is a gap in capturing more recent studies. Next is study selection transparency. The process for selecting studies is described, including independent screening by 2 authors, which reduces selection bias. But a flow diagram or more detail on how disagreements were resolved would enhance transparency. Next is data collection process and methodology. Data extraction procedures are outlined, but more detail on how missing data was handled or assumptions made would strengthen the methodological description. Next is data items and relevance. The outcomes chosen, migraine days and pain intensity, are relevant, but the study could have included broader patient-centered outcomes like quality of life. Next is risk of bias in individual studies. Using the Cochrane risk of bias tool is appropriate, but the summary could have included more discussion on how this assessment influenced their conclusions. Next is the summary measures and synthesis of results, statistical methods. The use of both fixed and random effects models is a strength, addressing heterogeneity. However, the choice of when to use which model could have been made clearer. Next is results study selection reporting. The PRISMA flow diagram, which is shown in supplementary material in the show notes, is crucial for understanding the study selection process, yet it would be beneficial if this were discussed more in the text. Next is study characteristics description. The descriptions of the included studies are somewhat limited. More detail on the diversity of tDCS protocols used would aid in the understanding of the variability. Next is risk of bias across studies discussion. There's mention of the overall risk of bias, but a deeper discussion on how this might have affected the results, especially with some studies having unclear risks, would be insightful. Next is the risk of bias across studies. There is mention of the overall risk of bias, but a deeper discussion on how this might have affected the results, especially with some studies having unclear risks, would have been insightful. Next is the results of individual studies and synthesis. The results are well presented with figures for meta-analyses, but the narrative synthesis could have elaborated more on the clinical significance of the effect sizes observed. Next is a discussion of the summary of evidence interpretation. The authors interpret the findings well, but could better contextualize the effect sizes with clinical relevance. Next is limitations and self-acknowledgement. The acknowledgement of limitations is good, particularly regarding sample sizes and study heterogeneity, but the discussion on how these might impact the applicability of the results could be expanded. Next are conclusions and justification. The conclusions are supported by the data, though they could more explicitly discuss how these findings might alter clinical practice or guide future research. Next is funding and conflicts of interest transparency. The statement of no conflicts of interest is clear, which is vital for credibility. In terms of the overall assessment strengths, this meta-analysis is a valuable synthesis of randomized In terms of the overall assessment of strengths, this meta-analysis is a valuable synthesis of randomized controlled trials on tDCS for migraines, with clear methodology and relevant outcomes. What are areas for improvement? Enhancing the reporting of study selection, providing more context on the clinical implications of findings, and discussing potential biases more thoroughly would elevate the study's quality. How about future directions, research recommendations? The study does suggest further research is needed, but more specific recommendations on study design, population focus, or outcome measures could help to guide future efforts more specifically. By applying the PRISMA framework, this critical appraisal not only assesses the quality of the study, but it also hopefully highlights how it can inform both practice and future research into the field of clinical neurostimulation, in particular for migraines. Thank you for joining me today on the Neurostimulation Podcast. I hope that you enjoyed this exciting exploration into the world of neuroscience and clinical neurostimulation as much as I did. If you found this episode interesting, don't forget to like and subscribe to the channel and podcast. It's the best way to make sure that you never miss an episode, and it's the best way to help us reach more curious minds like yours. Also, if you think that this episode might resonate with a friend, family member, or colleague, please share it with them. Knowledge is better when it's shared, and you never know who might find this information helpful or inspiring. For more details about the research that we discussed today and the associated technology, please check out the links in the show notes below. You'll find everything that you need to dive deeper into this particular topic. And I'd love to hear your thoughts. Join the conversation in the comment section below or reach out on our social media networks. For more details about the research that we discussed today, the technology associated with that research, For more details about the research that we discussed today and the associated technology, please check out the links in the show notes below. You'll find everything that you need to dive deeper into this particular topic. And I'd love to hear your comments. Please join the conversation. For more details about the research that we discussed today and the associated technology, check out the links in the show notes below. You'll find everything that you need to dive deeper into this topic. And I would love to hear your thoughts. Join the conversation in the comment section or reach out on social media. Your questions, ideas, and feedback make this podcast better. Finally, don't forget to tune in to the next episode. It's going to be another exciting and interesting journey into the cutting edge of neuroscience and clinical neurostimulation. Thanks again for watching and listening. Take care, and I'll see you next time on the Neurostimulation Podcast.